Good evening, ladies and gentlemen. We're just waiting for some more people to join. We'll start shortly.
Good evening, everyone.
Right. Good evening, ladies and gentlemen. Welcome to tonight's CPD session. Before I introduce the speaker tonight, I just want to point out that we are currently busy with a series on Fabry disease, and this series is sponsored by Takeda, but Takeda has no influence over the content of the presentation. The content is that of the presenter. And second, I just want to say that I know that we've had a lot of presentations now on Fabry disease, and maybe like me, you feel a little bit tired of Fabry. I do think, however, it is of value. There's some repetition, but there's always, in all of the presentations, there's also new aspects to consider. Since we started this series, we've diagnosed, I think it's 2 additional Fabry patients. So maybe that was just by chance, but I think that, the presentations definitely is having an impact. So tonight's speaker is Dr. Marli Dercksen. Dr. Dercksen is a clinical biochemist and chief medical scientist at the Center for Human Metabolomics. Dr. Marli Dercksen is a clinical biochemist with 20 years of experience in chemical pathology and biochemical genetics. Since 2014, she has been the chief medical scientist and consultant at the Center for Human Metabolomics at Northwest University, where she uses her skills to improve diagnostic testing, especially with mass spectrometry for small molecule detection and complex profile interpretation. Dr. Dercksen's work is particularly focused on rare disease diagnostics, including newborn screening and applied research. In addition to Dr. Dercksen's lab work, she published in peer-reviewed journals and trained students, young scientists, and the medical community in biochemical genetics. Some of her key achievements include setting up the first lysosomal storage disorder diagnostic platform in sub-Saharan Africa, helping create the first rare disease biobank in Africa, and working on policies to expand newborn screening in South Africa. She is also registered with the European Board of Medical Genetics as a clinical laboratory geneticist specializing in biochemical genetics, which she achieved in 2022. Solving complex biochemical problems, especially in rare diseases field, is deeply rewarding for her because it makes a real difference in the lives of many families. So I can perhaps just add to that Marli is the backbone of diagnostic services at the Center for Human Metabolomics. So I think we are privileged to listen to you tonight, Marli, and I don't think we can have a more appropriate speaker for this topic of tonight, diagnosing Fabry disease biomarkers. So thank you, and take it away.
Thank you, Chris. Thank you for the kind introduction, and good evening, everyone. I can't see anything on the chat function because I'm presenting on my laptop, but yeah, I'm sure the questions will come through as I go further. So the title I actually had was Diagnosis of Fabry disease, and as Chris indicated, my bread and butter is actually biomarkers. So I'm going to focus on biomarkers as a tool for the diagnosis of Fabry disease, trying to move a little bit away of the clinical side, but looking at the biomarkers itself and where it can be informative. But you would be fascinated on what a biomarker is actually defined as. So I will introduce Fabry disease, the clinical aspects in summary. I think this has been elaborated on in the whole series, so I'm not going to focus too much on it. The genotype-phenotype correlation, and I'm going to compare 2 of our patients that we've diagnosed. The age of onset. Is this an adult disease? I don't think so anymore after prepping for this presentation. The history of Fabry disease biomarkers, I'm going to just introduce you to that, and then I'm going to go straight into the biomarker workup, which include the routine chemistry, imaging and biopsy results, trusted specialized chemistry, and novel biomarkers looking at the lipidome. So, as you know, Fabry disease is a poster child of rare diseases in adults, and it's an X-linked genetic disease. as you know, and it's deficiency in GLA activity. And it's the accumulation of GB3 or GL3, if you want to, in all organs of the body. And below is a nice summary of the red flags of early diagnosis of Fabry disease. And typically it takes a multidisciplinary diagnostic team to manage these patients. And from 2019 until October 2024, we've identified 15 patients, and from ages ranges from 3 years to 45 years of age. So if I can just move this to the side. So there's genotype, phenotype diversity, and this is due to the X-linked nature of the disorder. So in males, we typically see the classical features, although attenuated forms also present. And in the females, we typically get the attenuated features and late onset phenotypes. And this is due to the X-linked inactivation phenomenon that occurs. So I'm going to just illustrate 2 cases to you and how different it is and how difficult it is, even with the most sensitive biomarkers that we have, to diagnose these patients. So the first patient is a patient with anhidrosis, arrhythmia, functional abnormality of the gastrointestinal tract, microalbuminuria, proteinuria, renal insufficiency. The kidney biopsy showed lipid deposits with zebra bodies. So this sounds pretty much like Fabry disease, and they have excluded all other causes of this phenotype. We were the last resort, but we did the GLA activity and it was normal. We did the lyso-GL3 and it was normal, but the kidney biopsy prompted us into doing the variant on the sequencing of the GLA gene. And yes, indeed, we did find that there was a variant, and this variant is known for not having a high GLA activity or a lyso-GL3 in the blood, but sometimes just accumulation in some of the organ types. And it's the later onset cardiac phenotype with renal involvement. So it can correlate with this specific disorder, and there's a lot of literature on this. The second profile, not related in any way, the patient has the tingling feeling in his hands and had left ventricular hypertrophy. And this patient had a clear deficiency in the GLA activity, had a clear elevation in lyso-GL3, and then had a variant which resulted in the premature truncation of a protein. There's limited clinical information on this, but this patient has, it's insinuated that it is cardiac involvement, but it has only been described in 1 paper. And this was actually not a recent patient, and I went back and still this variant has not been really defined clinically. So there's still a lot of work, I think, doing the genotype-phenotype correlation. So this is just the examples that we work with every day and the conundrums that we sit with in every day. So what about the children? So I just said to you, I'm going to discuss a little bit about the children and what is important in children. So there's actually a study, and this lady, if you go onto YouTube and you Google this lady, Dawn Laney, she has a great passion for Fabry disease in children, and they also screen for Fabry disease they have a newborn screening project, and they have followed patients from newborn screening until 7 years of age. And what they saw is that the lyso-GL1 is not trustworthy in infancy. They did skin biopsies, and they saw that the zebra bodies were indeed present in skin biopsies. They did some organ work as well. They saw GL3 accumulation, and these patients typically present with unexplained gastrointestinal issues. And what's very interesting is that there was already, during the prenatal period, in one of the patients, there was already in some of the organs, there were already accumulation of GL1. Verticillata is also present in the newborn, and then the gastric issues. That's a very prominent, and it goes right through to the age of 5 years old. So it's something to think about, even for our pediatric population and clinicians, is to keep that in mind. If you cannot find a diagnosis for your patient, it's worthwhile screening for Fabry disease perhaps, and perhaps look at the pedigree, the family pedigree, and look if there's men that has been affected by multiple clinical features of Fabry disease. And Dr. Irma is going to present on the 20th. She's going to present on pediatric Fabry disease, which I look very much forward to listen to. So, the history of Fabry disease biomarkers. So in the early 1960s, firstly, it was by enzyme assay. It was described as these patients have low GLA activity in men, and the limitation of this was actually that they could not detect females, and actually they didn't think females was affected because it's an X-linked disorder, and if you think of MPS II, why would the females be affected? So they didn't even think at this stage of females. Then from the 1990s, they saw that there was accumulation of the globotriaosylceramide, or the GB3, GL3, that's the same thing. And that is accumulation in multiple organs. And urine was actually the choice of matrix where they measured it. And they said that this metabolite was actually useful in the diagnosis and monitoring and disease burden determination in urine. But this was actually not the whole truth, because from 2008, we now are measuring lyso-GL3, which is the deacetylated form of GL3. And this could be measured in plasma and in whole blood. And this correlates closely with disease severity, symptoms, and organ involvement. And its use in the diagnosis of females were particularly important, and shows value in enzyme replacement and substrate reduction therapy monitoring. So the lyso-GL3 and the convenient monitoring of it in whole blood, dried blood spots is actually, for us in Africa, it's a big advantage, because it is a very stable molecule to measure, where the enzyme is not always as stable. I'll go into detail in that, but it's a really stable molecule to measure, and it's ideal thing then to measure in dried blood spots in an African setting. So my talk was basically on this paper, is based on this paper with some additional literature added, and expert consensus on recommendation of the use of biomarkers in Fabry disease. And it's really a great read. So I recommend that you go to this paper and look at it, because it informs you on biomarkers in each organ system affected by Fabry disease. So please make this part of your read-up as well. But before we go further, in this paper also, it was very interesting for me to get a clear definition of a biomarker. So the National Institute of Health Biomarker Working Group defined a biomarker as a characteristic objectively measured and evaluating the normal biological process, the pathogenic response, and the pharmacological responses to therapeutic intervention. So this ideal biomarker should be prognostic, likely cause of the disease progression with or without treatment. So it is a prognostic method, a prognostic marker. That's the ideal marker that we are looking for. And that's why we do metabolomics at our center, because we want the ideal biomarker. So the pharmacodynamic biomarkers measure the effect of the drug on the disease state. So we have screening, which has a high specificity. We have the diagnosis, which have a high sensitivity. So screening, we have a high specificity, high sensitivity. Screening is typically low cost. In this case, we have now, because of the growth and in lysosomal storage disease research, and because of therapeutic intervention, the cost is still low. And the diagnosis of the biomarker, or the biomarker, explains also the molecular pathology of the disease. When you have screening, you still have external factors that can influence. So with the diagnosis, the external factors do not have such a bigger influence on the biomarker. And then you have monitoring, which needs a high specificity. Otherwise, you do not know if your pharmacological intervention is really effective. You have low inter-individual variability, and you complement known prognostic indicators, and treatment response predicts sufficient treatment. So this is a great summary for me on what a biomarker is, and in my following slides, I'm actually going to elaborate furthermore on the biomarkers that we can use. So focusing on the routine chemistry of importance. So I must elaborate here that the routine chemistry is not the go-to for Fabry disease. It is just to direct you into a possible differential diagnosis. So you still need to consider other conditions resulting in the same routine chemistry outcome. But if you cannot explain your common diseases with the routine chemistry, Fabry disease needs to be considered. So first, look at the heart biomarkers. So cardiac symptoms in the classic and late onset Fabry diseases, most common in males before any other signs. So females is to a lesser extent. And we see left ventricular hypertrophy, mimicking hypertrophic cardiomyopathy. And the disease is already advanced if you see this LVH. So ideally, you want a biomarker that picks this up before the LVH occurs. Advanced disease, if it's here, then you have advanced disease, you have a poor outcome on ERT, and your cardiac biomarkers and imaging can be utilized in staging. So imaging is actually a biomarker. So a biomarker is not something that you can just measure in the laboratory. You can also use imaging as a biomarker. So you can already spot subtle changes. And I think some of the cardiologists that is perhaps in the audience can elaborate on this as well. And Prof. Chris gave an excellent talk on the cardiological features of Fabry disease in the previous session, and I recommend you go onto our YouTube channel. This is the link so that you can go and look further into it. So I'm just summarizing actually what he said. So the ECG, actually a 24-hour ECG, as well as a cardiac magnetic resonance imaging is recommended to pick up subtle signs. So what we want to do is to see the subtle signs early on so that we do not get to LVH and we do not get to LVH, and we can pick up these patients earlier so that we can give the patients ERT and then have a better outcome. So the ECG abnormalities is you will have a short PQ interval with a low T wave. So that's the initial, but it's very, very non-specific. So you can think, perhaps the cardiologist can think of several things that could result in this. I'm first going to go through the early ones. T1, T2 mapping is absolutely crucial, and a low myocardial T1 is actually a very good indicator in this, with regards to Fabry disease, and this is on the cardiac magnetic resonance. And then your late gadolinium enhancement, I'm just going to following the talk, I'm going to speak of LGA. So there's plus minus 50% of the patients with a normal ventricular mass. So they do already have this, but they have still normal ventricular mass. So if you have a delayed CMR assessment, then you see already a severe reduction in the T waves correlating with LVH. You have a low myocardial T1, but you also have a high and a global T2, and you have extensive LGA with LVH confirmed. So you want to pick up the patient here. You don't want to pick up the patient here because it's too late for these patients. It may not be too late for other patients in the family that's younger, but it's too late for these patients, and ERT outcome is poor in these patients which already have these symptoms. So markers are disease-specific for diagnosis and follow-up of Fabry disease progression. So the measurement is highly dependent on the stage of the disease, so early and late detection, as I indicated just now. So the most sensitive marker that we have, it's a high sensitivity troponin T. So before treatment, advanced disease, poor prognosis, ongoing myocardial fibrosis. After ERT, this marker is not informative in any way. The BNP is a marker for left ventricular overload, and the combined high sensitivity TNT and BNP is used to detect myocardial fibrosis in hypertrophic cardiomyopathy. It is, however, very non-specific, can be normal or abnormal in treatment. And I can just shift this up. It is high at diagnosis, but it does go gradually down when ERT is administered. And then a high NT-proBNP is reduced in the left ventricular systolic function, and this is directly correlated with the renal function, the eGFR. So the plasma correlates with the left atrial size and the LVH. And before the treatment, the sensitive markers, depending on the disease stage, again, when you do the ECG and the cardiac magnetic resonance. And again, ERT, this marker is not informative in any way. So above biomarkers is only informative with disease-specific markers such as lyso-Gl3. So measuring these alone will not give you an indication. You must measure it with lyso-Gl3. So if we go to kidney markers, the diagnosis, albuminuria, important glomerular marker of proteinuria. So it is currently the golden standard for Fabry nephropathy in the second and third decade of life. So ideally, you want to pick up the patient before the second decade of life. So you will not always you will probably see the patient when there's already albumin or albuminuria, and you do not actually want it. So assessment only of the proteinuria without albuminuria delays the diagnosis. So doing both is very important, and it's a cost-effective way. If you are in the state sector, and you are aware of this disorder, it is perhaps a cost-effective way for you to just screen this patient. But again, there's so many conditions that could result in albuminuria. So post ERT, evidence is mixed. So you still can get it. The ERT before 30 years of age, the albuminuria is informative, but the albuminuria after the age of 30 years, which most of the Fabry patients are currently diagnosed, is not specific. So actually the kidney biomarkers that we have in the routine chemistry lab is not informative. And then we have the additional interferences of the ACE inhibitors. And then also you must recognize that patients are on different doses of ERT, and the picture is unclear for patients on substrate reduction therapy. So there's a lot of factors that can influence this specific biomarker. But what about the glomerular filtration rate? So this is a very important parameter in Fabry disease. Untreated patients, more reduced in classical Fabry disease than in attenuated forms, and practical implementation of this is difficult. So we use the estimated eGFR, is more practical, and we can base this on serum creatinine. This has its limitation because you have your muscle mass of the patient that may differ. And now more and more labs are validating cystatin C. I know in the private and state sector, I spoke to them during the last 2 weeks, and most of them are looking at this. It is a more expensive test to do, but it's less subject to bias and more sensitive in detecting early kidney damage. So provide an independent muscle mass and can potentially be used in early stage Fabry disease nephropathy. But again, cystatin C can also be due to other glomerular related pathogenicity. So what's for us to do is the CKD-EPI. This is, everyone knows, this is a chronic kidney disease epidemiology collaboration equation. And this provides a better definition of the cardiovascular burden as well. So the relationship between the CKD and the cardiac function, the abnormalities of the kidney in the structural function present for longer than 6 months. So you can have an EGFR creat, which is, we do not think that would be really informative. The cystatin C can perhaps be more, and perhaps a combination of the two can be more. So ERT reduces the rate of reduction, but of the EGFR, but the extent is still undefined, and it is very much dose and regimen dependent. Now, just to give you an indication, there was also a study which they call the Unstable Fabry Stabilization Index score, which was done in 31 Fabry patients, or 32 male classic Fabry patients, and they all have a low EGFR score of approximately this. So if you have a low EGFR score of approximately this, then you know you are you have a classic Fabry disease patient. And then external factors, again, like your ACE inhibitors and your ARB, reduces the EGFR, and this can interfere with your interpretation. So if your patient is on hypertension meds, then it can perhaps influence your EGFR, and you can, okay, no, the patient is on therapy, that why should I now test for Fabry disease? That is likely the cause for the reduction or the slight decrease in EGFR, and you will miss a patient. So the therapeutic goals should be personalized. So you look at the whole picture, not just the kidneys, not just the cardiac function, look at the whole picture. So what I also, from Prof. Chris's previous presentation, is the podocyturia, which can potentially be a very informative way in looking at, and we actually are discussing it in a study we are looking in next year. So confirm that there's accumulation in the granular lesions. So the GL3 is located in the podocytes, long before clinical symptoms occur, early stages of the disease. So it's even in early childhood. So they have done kidney biopsies in children, and they have seen the accumulation of GL3 in podocytes. And the morphology changes even before proteinuria is present. So even before you see it, you can have it. And these podocytes are then, you get urinary loss of the podocytes. And this is in relation to the glomerular injury. And this is, again, correlates well with the clinical severity in FD nephropathy and classic FD. Attenuated FD, it has not been looked in detail because there is no standardized protocol to do it yet. And we'll see, maybe we can get a standardized protocol set up. I think it can be something which is very achievable in an African setting. Yeah, so if I now go further, let me just see, I can't see my heading. Okay, but what about the zebra bodies? I think that is what they're standing there. What about the zebra bodies? So classic features of Fabry disease is electron microscopic investigation and that of the kidney biopsy. So there is layered membrane structures, and they're called zebra bodies. And it's actually myeloid bodies, or MB. So you can search both of these. Don't just search for zebra bodies, look for both of these in the literature. And these are found in large lysosome, mainly in the podocytes, but it can be in other parts of the kidney as well as the disease progresses. But one should be aware that this is not a unique biosignature for the disease. And it's illustrated in this excellent paper that was published in 2022. And I'm going to focus on this paper now further on. So the Fabry disease group in this study is extensive myeloid bodies, not only in the podocytes, but also in the parietal, tubular, endothelial, and the myocyte cells within the kidney. Half of the FD group had another superimposed renal disease feature, including copper light chain deposit disease and thin based membrane nephropathy. So I think they had about 44 patients or 52 patients. They had 6 Fabry patients, and half of these Fabry patients had these copper light chain deposition deposits and thin based membrane nephropathy. The non-FD has less extensive involvement, but overlap of FD group exists. So I'm going to show you now the difference in the zebra bodies, specifically how it looks. And this is a great paper where they compared 2 case studies with each other. The one is where the zebra bodies was acquired, and the other one was due to Fabry disease. So the first one is actually the Fabry disease I want to discuss. So this patient had classical Fabry disease patient, pain and paresthesis, proteinuria, renal ultrasound was normal, but there was already cornea verticulata and angiokeratomas were present. There were the left ventricular wall thickness were present, and a clear deficient GL activity with a pathogenic mutation was identified. And in image F and H, you could see there's intralysosomal zebra body. So this is the lamellated podocytes. So you could see the clear zebra bodies here and here to a more extreme extent. And in G, you can see that there's endothelial cells in both the glomerular, in the white arrows here. And F, there's also white arrows here. You could see that there's peritubular capillaries also. So it's not just the zebra bodies. You can also see that there's endothelial cells involved, and the peritubular capillaries were also involved here, as you can see here. So if you go to acquired zebra bodies, so this we typically see in lupus patients that's on hydroxychloroquine treatment. So this patient also had zebra bodies. So we were actually the patient was actually referred to our patients, and they sent us the imaging, and they said, but look at this clear zebra bodies, and is this not Fabry disease? So in A and B, the intralysosomal, lamellated and podocytes, so the black arrows indicated it, but you can see the extent is not nearly the extent that you see in these podocytes. And podocytes present cytoplasmic swelling, still present, and absent zebra bodies, no lipid deposits were in the black. So in the first biopsy, you could see this was a clear zebra body image, but this was the second biopsy. And now the zebra bodies are absent. And this was after discontinuation of hydroxychloroquine. Today, Prof. Chris asked me how long after this was between the first and the second biopsy. Obviously, you cannot do just biopsies just when you want to. So it was actually 3 years after it. This zebra bodies was associated with proteinuria, and after discontinuation, the proteinuria was also absent, and then after 3 years you could not see any zebra bodies. But the stage of which this resolve, or the timeline of its resolve, I could not find any timeline on this. This was the only indicator to me of the biopsy was taken 3 years later and no zebra bodies were found again. The biopsy were taken 3 years later because the patient had proteinuria, but no zebra bodies. So what about zebra bodies in the skin? So this is an easier way of not having that invasive renal biopsy taken, doing a skin biopsy, and you then have a skin electron microscopy that you can do. So you can also see characteristic zebra bodies here in this image here. It's not as clear as in the, but it was in this paper. So you can see, and this is endermal fibroblasts and deposits of heterogeneous morphology in the lysosomes. Here you can see it in the lysosomes. So you can see the storage signs in the lysosomes. An increase cytoplasmic volume caused by prominent storage then moves into the endothelial cells. So there you can see now it's moved into the endothelial cells, and then it's actually invading the vascular lumen in this section here. So interesting, the storage clearance in fibrous and endothelial cells after 1 year, after ERT in 1 year, it disappeared. But it was just only in male patients. In female patients, it was not as prominent, the disappearance. That was an interesting fact in this specific paper. So if you can go back to drug-induced phospholipidosis, so resulting in zebra bodies, these are actually all the medications that can result in drug-induced phospholipidosis. So if you do have a kidney biopsy or a skin biopsy, and you do see some of these, and your patient is on these medications, such as hydrochloroquine in lupus, then you should consider this before automatically going to a diagnosis of Fabry disease. You can, being non-invasive, not doing, again, stopping the medication and doing it, you can just do a Fabry screen with us and just see if the patient has Fabry disease. But it's important to notice this. And then I also found that there were also kidney podocyte zebra bodies in lung transplantation for a certain condition. And then we also saw in, again, just in systemic lupus, we see this again. So just be aware of this as well, that you can see zebra bodies together with your proteinuria. So what about the central nervous system and imaging markers there? So I heard that this was not covered, and I'm not going to actually cover it in detail, but I think it's worthwhile just mentioning a few facts here. So the main findings is that it's non-specific and non-sensitive. So you have white matter hyperintensities. You have cerebral microbleed suggestive of cerebral small vessel disease. So there your pulvinar signs are important to be on the lookout for. The latter is 24% higher in males than in females. And then your perivascular spaces are prominent there, but there's overlap with other LSDs, like your mucopolysaccharidosis also has perivascular spaces. And this goes together with cognitive impairment. So this is already an advanced disease. And what's very interesting is the dilated and elongation of the basilar artery. And this is a very early sign of Fabry disease. So it's actually, I would think this is the most important. I actually should have made it in red. This is a very, very good central nervous system marker that we could actually look at and see if this is a potential Fabry disease patient. And the diameter of the BA predicts the value when it have predicted value when response to ERT is measured. So a study of 30 patients showed this. So this it's not dilated or elongated anymore if ERT is applied. But this is just in this one study, so more studies are required within this. So biomarkers now specifically, going back to the initial history of the biomarkers of Fabry disease, we now have the biomarkers of Fabry disease, which I'm going to discuss again, with a high specificity and sensitivity. We have low GLA activity in men. and that is seldom detected in female patients. I think we have one female patient that had a low activity now recently. And then the high lyso-Gl3 in dried blood spots and plasma. This correlates closely with disease severity and organ involvement. It's specifically important in female patients. You cannot just measure GLA activity in female patients. You need to measure the biomarker. And that could still be normal, as in the previous patient I did show you. So still female cases, as I said. So the skin biopsy may be an option to look for zebra bodies. It's a little bit less invasive than a kidney biopsy. And maybe we still need to look at this if it's really informative in females as well as in males. So this, for me, if I look at the whole picture of biomarkers, I think this is the way in which we should proceed. So I just went, I think you saw this in the previous presentation as well. We now have 15 patients. This is, the 15 patients have phenotypic overlap. So some patients have more than one. So one patient only had renal issues. Most patients that we've seen had cardiac issues, 2 had eye issues, vision, not corneal verticillata, but had vision problems, skin problems, 1 had eczema, 1 had angiokeratomas. Gastrointestinal issues were also there, but I suspect that this is actually a higher amount because these patients may have gastrointestinal issues since childhood, and this is the least of their problems. The other problems is much bigger than gastrointestinal problems. So I imagine that this is not even mentioned in sometimes when we get the clinical information. 4 patients was actually tested based on the family history. So just need to look at my time. So family history. So I know the youngest patient was 3, and it's because his 2 uncles that lives in the UK was actually screened with a positive Fabry patients, and they screened the 3-year-old child, and the patient already had increased lyso-Gl3 in the dried blood spot. 2 did not provide any information to us. So just to give you an indication, I always show the sign, this because it is so important when you fill in your referral to our lab. So you will have your dried, this is a great way in collecting your dried blood spot. This was a Fabry referral, and the Fabry is ticked. If it was a male, this is a female. So if it's a female, don't worry, we will in any case do the lyso-Gl3, but tick the lyso-Gl3, it's always good. If you have a renal biopsy that shows you that there is an indication of Fabry disease, we will do the GLA activity. But if you have a high clinical suspicion, you can always communicate with our lab, and we will refer, even if it's normal in male patients, we will refer it for lyso-Gl3 and subsequent sequencing. So from 2019 to mid-2024, we have done 3,274 lysosomal storage disorder screenings. That this is not for Fabry, it's for all of these disorders. And again, I can just show you that we have a 1 in 24 patients tested positive, or 25% positivity rate, if I say it correctly now. And you can see this is a normal. And then you can see there's an artifact. The artifact is when the 2 or more of the enzymes are low. And this makes it extremely difficult for us to make a call if this patient is affected or not. We do use the Mayo Medical Laboratory post-analytical tool to assist us with the differential diagnosis. But please make sure that you collect your sample correctly, and I'm going to just show you some pointers in how to do it correctly. So various factors should be considered. So type of card, type of blood, optimal handling after collection. So the dried blood spot card in the kidney is a Wapner 903. You know the correct spotting as I showed you here. Don't oversaturate, don't overlay let it dry, overlay it again with blood. Do a finger or a heel prick. Don't spot it with EDTA. EDTA interferes with our LC-MS analytical platform. Temperature after collection for drying, and drying time is very important. Don't leave it on the heater to dry. Don't leave it in direct sunlight to dry. Let it just dry under room temperature. Room temperature, I don't mean 34 degrees like we're experiencing now. So room temperature, European room temperature, if I can state it like that. Storage temperature, very important, and also having the desiccant bag within your bag when you send it to us. This is very important so that the humidity do not influence the stability. We see it a lot from UKZN and from Cape Town, or the Cape region, that we do get artifacts on a lot of those samples. I know it is frustrating, but it is the humidity. The humidity sometimes plays a bigger role than the temperature. So please make sure that you insert that desiccant desiccant satchel in the bag so that we know it. And please make sure that it is shipped timeously to our lab so that we can test it as soon as possible. So what is potential biomarkers for the future? So my main goal is to diagnose classic as well as attenuated forms. So we don't want just this one lyso-Gl3 marker. We want more sensitive markers. So can we do it via omics-driven approach, identify new biomarkers, find biomarkers which is increased sensitivity and specificity, cost-effective from an African perspective, and sample matrix easy to collect. So it's non-invasive, dried blood spots accessible to African countries. So, and actually there was a proteomics study done, and this proteomics study was a comparison study between Fabry disease, Pompe disease, Niemann-Pick C, Gaucher disease versus healthy controls. And in this study, actually, interleukin-7 was a promising in non-classical Fabry disease. So this is actually, I don't think you see it, but in classical disease, in males, classical in females, classical in males, you see that in all of it, in the attenuated forms, it is informative until there. So interleukin. There is other markers as well. So they compared the lyso-Gl3 with the interleukin-7. So you can see that it is a promising biomarker from a proteomics perspective. And then this is our bread and butter at the Center for Human Metabolomics, is plasma and platelet lipidome changes in Fabry disease. Also a great paper. And this seems like a daunting, I never want to actually show these daunting kind of metabolic pathways, but it's very, very interesting that there is some additional markers that can be beneficial, like the sphingosine-1 phosphate. So, and interesting, the sphingosine-1 phosphate and the lyso-Gl3 is directly related to the LGE on the CMR. So, and this is a very, very good relation that we can compare the cardiac magnetic resonance with the two biomarkers and get a better picture if this is attenuated form or if it's, we can diagnose it earlier, and if it's attenuated or classic. Then we have other species that's also like, here in red. So we have your lyso-Gl3, and then you have others. You have your lyso-Ga2, that was also important. And then you also had your GB4, and then interesting, your GM3. So your gangliosides were also, GM3 ganglioside were also very important. So measurement of these metabolites were different in platelets and plasma. increased prothrombotic state has been reported in FD. So we think that platelet lipidome may be more informant in classical versus attenuated. So because of the prothrombotic state that's affected in FD. So perhaps plasma is not the ideal thing to look at, but platelets might be, but whole blood is on red blood spots, lipidomics on that, because that also contains your platelets. I think it would be a great project to participate in. So the proposed diagnostic algorithm, and I'm well within time. So if you suspect a Fabry disease patient, if you have your classical patients, you will have a low GL activity with a high lyso-GL3. And then you will do your sequencing. It will likely be confirmed, or you will get a variant of uncertain significance, which you do not actually know, okay, if it is. Most of the variants have been is in the Fabry registry, so and have been really well defined. But like I said, there was one that was once identified, potentially associated with cardiac involvement. So it is actually technically still a VUS. And for this reason, the clinical side is still very important. And we can also have a low GL activity with a high lyso-GL3, but you can still get a negative sequencing. So what do we do now? We now need to sequence the whole gene so that we can look at the intronic region and looking at these splice site mutations possibly that we did not pick up with the next generation sequencing approach. So it can be negative. And again, it can it's a reason then to do the whole gene sequencing thing through whole genome sequencing or summer sequencing of the GLA gene. So if you do get a variant of uncertain significance, or if you get a normal GLA activity with borderline or normal lyso-GL3, but there's still a high clinical suspicion, there's two sides to the story that you must follow. First of all, you need to do a pedigree assessment, and the genetic counselors could really assist you with this. They are great, they're experts in this. They will look into the history of the family and they will see what males, specifically what males have been affected, what their clinical symptoms is, was there early death in the male patients. And this could give you an indication that you must, okay, focus is still on Fabry disease, or focus must maybe shift to a different disease. Otherwise, you can also have your specific indications, such as your cardiac MRI, your brain MRI, and your renal biopsy or skin biopsies. And this could be informative, or it can be non-informative. And if it's non-informative, then FDA or FD is excluded. Fabry disease is excluded. If it's informative, you need to do the sequencing again. So if you have a normal GLA, borderline normal lyso-GL3, I recommend you follow this route. If you do suspect a Fabry disease based on the evidence provided here, then you do the sequencing, and we gladly do it. We've done it for a few patients, and we can get then a sequencing result and hopefully get your patient confirmed with Fabry disease. Or perhaps we will get a VUS and we need to establish if this is indeed a mutation we want to look at. And I thank you for your attention. And I really like this. It was actually in Science volume 379, issue 6637, which they looked at LDL, HDL, and there someone is shining a light on the ceramides. And the ceramides are the GL3s and the GL1s and the lysos that we are looking at. And we need to shine a light on that to understand lysosomal storage disorders better. Thank you.
Thank you, Marli. It's a lot to take in, but fortunately it's recorded, so one can go back and watch it again. If you
In
do have
time, I'm actually in time. I'm
yeah,
almost,
we do have
I'm all,
time for some
yeah,
questions.
I'm always over time, so
Okay, so
yeah.
if you do have questions, you're welcome to post them in the Q&A section. Just check not in the chat function and the Q&A. While we're waiting for some questions, I can perhaps ask you one. So in the current sixplex LSD assay, we test for Gaucher, Niemann-Pick, Pompe, Fabry, Krabbe, and MPS1. And all of those do have metabolic markers as well. Do you think we need to move?
Chris, I missed you. Sorry, it broke up. Your line broke up. Just say again
Where should I start?
from the beginning.
Oh, from the beginning, yeah. So, I mean, in the current sixplex LSD assay, we test for Gaucher, Niemann-Pick AB, Pompe, Fabry,
Yes.
and Krabbe disease and
Yeah.
MPS1.
Yeah.
And all of them do have metabolic biomarkers. Do you think we need to change to metabolic markers as a first tier screening test and then confirm with enzyme assays as opposed to the approach that we're currently following where we basically screening with enzymes?
I like the biomarkers, but the enzyme just gives us a next level. I will actually turn it around. I will actually maybe turn it around. Yeah, we don't have, because the enzymes was the first thing that we validated in the lab. That's why we do it, the enzymes, and then the biomarkers. But taking the females for Fabry disease, I would turn it around. Perhaps not for the others, but for Fabry disease, I would perhaps turn it around. But I think it's because I'm a metabolite person. I'm a metabolite actually. That's my bread and butter. So although I did a lot of enzymology as well, but I think having both in your laboratory is so important. I think exposing the staff to measuring enzymes and measuring metabolites and understanding what the protein does and what the metabolites is all about. I think both is advantageous. But I think from a financial perspective, perhaps if you're gonna ask money-wise, perhaps a biomarker is a better way to go, in my opinion. And because we are struggling with humidity and with temperature, yeah, I think perhaps a biomarker, but perhaps Chris is also here, so Chris Hendricks is also here. He could perhaps, just thinking in my mind in an African perspective, what is more stable? A metabolite is more stable. So, yeah.
Okay, before I give Chris a chance, Trevor is asking how can we get hold of the presentation. So we have a YouTube channel where all our previous presentations are posted. And when I give Chris Hendricks a chance, I'm quickly going to find the link and then I'll post it in the chat. Chris?
Yeah, so I think it's a fascinating question. And I think my view would be, I think we do struggle with enzymes, especially transporting them over long distances. And we know it's a particular problem. So the DBS samples for enzymes are not as stable as everybody else tells us in the world. Once we expose them to African temperatures, humidity, and travel, they don't seem to be that. So from that perspective, I think some of our biomarkers are more stable. But then, of course, it depends on what you're looking for. I think if you know which disease you're looking for, I would most probably still go for the enzyme first. If I'm not sure, I would most probably go for the biomarker because you may get a bigger yield. So as an example, I'm very concerned about the lack of Fabry patients that we see in the sub-Saharan Africa. But if you look at all the data from everywhere else, there should be a multitude of patients. So would it be more cost effective to go into a cardiomyopathy clinic and basically just do lyso-Gl3 on all of the patients who attend, who agree and consent, and then pick the ones out with a high and then start investigating them further? And that was most probably the way I will do it at the moment until we've got better ways of collecting samples. we've not looked, and I'm just starting to look into that with samples coming from Kenya, is there's also the new, which I'm sure you're aware, the remote collection devices. There are about 50 of them around now, Tasso, OneDraw, all of them. Now, there's some indication that if you collect your enzyme directly into them, they may be much more stable than spotting them. So again, this is early work, and I think we need to look on it. So I don't give you a definite answer, but I have your emotions as well. I think that if it comes to cost, I think doing a biomarker naturally seems the easy way to look at a bigger population. But when you look at a specific patient, I would most probably still go for enzyme. And I'm sure in a year's time, I'm going to say we'll go straight to gene and we'll deal with the bioinformatics and the other things most probably.
Yeah, I can just indicate that we're working on a multiplex lyso panel. So it will not just be one biomarker for one disease. It's not cost effective to do it in that way. So we will always look at the lysos. And even combine it with the peroxisomal lysos. So it will be a multiplex analysis, which would also be cost effective and cover more ground in that way. I can just reiterate that if you want to ever do newborn screening, this is another ballpark because GLs3 in neonates and infants are all over the place. So according to the literature that I've now assessed. So for them, enzymes are still the way to go if you go into neonatal screening for these disorders. But using the lysos is still all over the place. And that is true also for doing GAGs in neonates and infants. It's all over the place. So early infancy, it's all over the place. Late infancy, not that more anymore, but it's not. Early stages, it's not. But if you are older, then it seems like it stabilizes, and then you can get a set reference range. And the reference ranges even that we have now is not age-related even, which I think is really a need. We only have one reference range for lyso-GL3. No one has looked into that. We're looking into that now. So I think it's something that needs to be looked at. No one's looking at it.
Yeah, I agree. I've posted the link to the YouTube channel in the chat section. So if you want that, just go and you can just click on it and then just bookmark that that YouTube channel. Marli, I'm also thinking, that slide that you showed about the metabolomic studies. I imagine that, if the disease becomes advanced, then you get generalized lysosomal dysfunction, and many of the sphingolipid intermediates are going to start to increase. Just like we see in organic acidemias. So will our multiplex metabolite panel be, will have similar problems to what we experience in, for example, organic acids when patients have got very advanced disease, that it actually becomes difficult to distinguish, to actually make the diagnosis based on the fact that there are so many perturbed sphingolipids, because most of these diseases are going to give you perturbed sphingolipids.
Yeah. Well, I know the Mayo Medical Laboratory has a multiplex lyso assay. So it's perhaps something one can discuss with them. And perhaps it's again something on reference ranges that we need to look at. So you will have a CROBA marker, but it will still be within reference range. It will be there. It will be higher, perhaps, but it will be there. Unfortunately, we cannot do the metabolomics on each of the diseases on the 6-plex. We need 6 PhD students for that. which would be cool, but yeah. I think reference ranges will be the key there. And why no one is looking at it is I'm really struggling with it. Because it was looked at in urine, but and I'm uncertain if it was looked in plasma, but it's not looked in dried blood spots. So it's really, for me, it's maybe the hematocrit thing. I don't know. Yeah.
Yeah, I can add there, Marli. I think it may be a question to repeat to Uma as well. As far as I know, we did look at the reference ranges and the difference between male and female and children, because of the
Yes.
variability, made it a nightmare for Fabry. For MPS disorders, we do have age-appropriate reference ranges, and as far as I know, that is for both blood and for urine. And it is one of the important things that you do need to have an age-appropriate range. And it's really important because especially the urine gags is particularly sensitive in age-related situations. Yes. And we're seeing the same now in oligosaccharides. Exactly the same picture is coming out, that reported values actually came out once you sequence them, they come out abnormal. So I think for all of us, I think old-fashioned medicine should win. I think if you believe your patient has got a disease, I don't say fight with the lab. I say speak to the lab and say to them, listen, guys, are you sure? I've looked at this patient. It really looks like this condition. Is there another test we can do? And I think with your multiplex, maybe one of the things to know, and what Chris said as well, is we were slow off the mark with the other profiles to do that. I think maybe from the beginning, if you've got a project, start looking at ratios. Because we actually found that you find that sometimes the ratios are really distinctive.
Important.
Yeah.
Yeah. So we will probably also use that function on the CLEAR tool from Mayo Medical Laboratory, because they do the lysos, all the lysos in multiplex, and they look at the ratios there as well. So we will probably look into that as well.
Perfect.
Yeah.
Okay. There are no more questions in the Q&A, and we are already over time. So Marli, thank you very much for a very interesting presentation. Chris, thank you also for your contributions, and thank you to everyone in the audience for your attendance. We look forward to seeing you at the next CPD. Have a great evening and good night.
Good night. Thank you. Thank you,
everyone.
everyone. Thank you.